Hi folks, Phil Russo here. Welcome to the next episode of Infection Control Matters. Delighted to be joined by Martin Kiernan. Hi Martin.
How are you, Phil? Good to see
I'm
you.
well, thanks. How are you?
Yeah, good.
And we have two guests today who you actually know quite well, Martin, I believe over the years. Melissa Rochon from Guy's and St Thomas's Foundation Trust in London. Welcome, Melissa.
Good morning. Thanks for having me.
And Judith Tanner, who is well known to many of us from University of Nottingham in the UK. Welcome, Judith.
Hi, Phil. Lovely to see you.
Good to see you all too. This is a particular interest of mine, and probably just to bore the tears out of everybody who I speak to about this. It's about surveillance, and it's about an efficient way of doing surveillance. You've previously done work in this area, and I'll perhaps just do a quick recap. A couple of years ago, you did look at using a digital platform for post-discharge surveillance and looking at the clinician response times and surgical site infections and the carbon footprint of that, which was also novel at that time. You've now taken this project a step further and done a randomised controlled trial where you've compared the digital platform that is used to monitor surgical sites post-operatively and compared it to standard care. And you've looked at a number of primary and secondary outcomes, and you've just published it in the Journal of Hospital Infection. So thank you very much for that. It's really fascinating work, and I'm looking forward to hearing more about it. So perhaps, Judith, I think I'll throw over to you. If you could just tell us a little bit more about the study.
It's fantastic to be here because a few years ago you asked us to come along and talk about this area, and we were just starting out. So it's really great to be able to come here and give you some of the findings.
Turned out to be a very popular podcast, that one, Judith, so no pressure this time.
Oh, that's probably just Melissa and I listening to it over and over again. Well, what's really interesting about this study is, as you say, Phil, we started out with the digital monitoring. The platform's called Isla, and we started out with that. Melissa was leading the work on that at Guy's and St Thomas's, and we were really victims of our own success because the platform, patients loved it and engagement was really high. So lots of patients were using it. They were sending in lots of photographs. And this is absolutely fantastic because these are new patients who've not been followed up before, but now they're getting their wounds monitored. But the problem was that this was additional work. This is new work for our staff to look at the photos and look at all the data. So the idea that Melissa and myself came up with was, if this is going to grow and we want to be able to scale this to other hospitals, how are we going to achieve this? Let's see if we can get AI involved in this. And the idea behind the study we're called Wisdom, the idea behind that was really about how is it we can get staff to manage this workload if it's a new and increasing workload? How can we do this at scale? So what we wanted to do was, how can we involve AI? And is it possible to develop an AI model that will look at the photographs, the images that the patients are taking, and can the AI model identify or detect signs of wound problems or wound infections in those photographs and prioritize them, like triage them, so that those are the photographs that staff look at first. So if you've got 100 images in front of you, 100 patients sending in data on that day, which ones are you going to look at first? You're going to look at them all, but which ones do you prioritize? So that was really the agenda, was to see if we could get the AI model to do that. And then once we developed that model, we would obviously test it with images, but we wanted to do a feasibility study and test it in a trial with real patients. So that's what Wisdom 1 was about. Do you want me to go into the bit about the AI model?
Please do. Thanks, Judith. Yeah.
So Melissa and her team at Guy's, they've already been using digital monitoring. So they've got a whole bank of images. So that's what we were using to develop the AI model. And we had just over 40,000 images. So what we did was we started off with those 40,000 images, which is a huge amount of images. If you look at other studies where patients are talking about using AI, they do have some banks of images, but often there's just like 100 images. So for us to have 40,000 was absolutely fantastic. Obviously, we had to remove all the patients who had opted out of being involved in any research studies. So we removed those patients, and then we anonymized the images. We got rid of any poor quality images or images that had anything that could identify patients, tattoos, or there was a dog in the background or something. So we got rid of those images, and we were left with about 38,000 images. And then we took our testing data set. So these were the images that we would use to test and see if the AI model worked. So we needed just over 3,500 of those. So we removed those. And then to prevent contamination, we had to remove any patients who were involved with those 3,500 images. So we had to remove another 10,000 images. And we were left with 28,000 images. And that's what we're going to use to train our AI model. And we got a group of clinicians who were specially trained. And what they did was they annotated, they labeled these images. So they were looking, for example, to put a box around the scar so that the AI would know which part of the image to zoom in on.
Sure.
So they would do that, and then they would also label the images for signs of necrotic tissue, slough, granulation, bleeding, exudate, pus, stitches, staples, discoloration, any incisional separation. And then that work would be checked very thoroughly. And that was put aside. So that's our training data set. And then we also had the testing data set. That's our 3,500 images. And that was not labeled. They weren't labeled, but we had clinicians who looked at those and said if there was a problem or not. So that was in another bucket. So then the training data set. So that's then presented to numerous computer algorithms. And those were run with the 28,000 images. And what that was doing at that point was training the algorithm to identify any pictures that had any of those signs of wound problems or infections included within the image. So once that had been done, then we were able to take our testing data set, that's our 3,500 images, and that was shown to the algorithm, and then the algorithm said, yeah, we think it's infected or it's not infected, or there's a wound problem or not. And what was great was we got a sensitivity of 89%, which was fantastic. So we're absolutely delighted with that. That was really brilliant. But it varied across different skin tones.
Yeah.
So what we wanted to do then following on from that, I mean, that was what we had was great, and it was higher than what we were expecting. We performed better. But what we wanted to do was do some further work around skin tones, and that was Wisdom 1.1. So where we did some more work developing sensitivity across the different skin tones. So that was the AI training model bit. And then for the actual feasibility study, that's where we had 120 patients at 2 hospitals, one in London and one in Newcastle. And you've already gave an overview there with half of them had usual care, and then the other half were randomised to have the AI model.
Just before we move on, just curious, with the training, was the wound on the same body site, or were they wounds from all over body sites?
I'm going to pass that to Melissa.
So we were really fortunate because we're covering a number of surgical specialisms. So we had a large array of incisional sites.
Thank you. I was just curious because the study that you're about to talk about was cardiothoracic surgery, wasn't it? Yeah.
Yeah, I was wondering why you picked those, but presumably you've got a long experience of working with digital monitoring of that area anyway, so it's an area that's very familiar to you.
Absolutely, yeah. I think we're inheriting a little pre-COVID know-how, which was we had already standardized for photo at discharge, which made us rather unique. We had examples of healthy wounds as well as wounds with early signs of concerns, also avert surgical site infections. So yeah, cardiac is definitely our beacon service.
So perhaps you just give a quick oversight of what the intervention actually was. What does it actually involve?
So for us, the intervention arm offers ILA, which we've already mentioned. It's a platform that doesn't need to be downloaded, or the patient doesn't need to register for or install anything. It's a browser-based approach. And patients can receive either text messages or emails. Now, texts have been around for the last 40 or so years, so we know people know how to engage with that approach. What makes us, I think, relatively unique in this space is we're keen that patients engage with a healthcare worker at the other end of their submission. So they're sending in a photo as well as structured wound healing questionnaires. But after that, they're probably going to receive a response within usually an hour, giving advice or reassurance, referral if necessary. And I think that makes us in this space, a lot of people are running towards making it automated so that there's an algorithm that says simply X or Y. But we know from earlier works that patients value digital if it enables them to have access to healthcare or open up that communication. So that was really important to us. So for the intervention arm, we were offering a schedule of every 7 days, we'd ask for these photos and this wound healing questionnaire. But if a patient noticed concern in between, they can also initiate their own follow-up, which makes it, really user-friendly.
So the patient takes a picture of the wound, does a questionnaire, it's reviewed by a clinician. If the red flags are up, then the clinician will look at those first, and then there'll be some response to the patient.
Missed off the AI bit entirely. Apologies. So yes, so the patient submits and the algorithm runs in the background prior to the review by the clinician, and it says simply, look, there are signs here, and Judith mentioned these can be discoloration or redness, incisional separation, unexpected tissue or fluid, or wound closure materials like staples that shouldn't be in after a certain length of time. And it says simply, look at these first, which helps people plan their workday if you need to bring somebody back into wound clinic or similar.
Can I ask a bit about recruitment? Because you had just over 300 people were assessed for eligibility, but only 121 got through to randomization. So some couldn't access smartphones and other issues. What does that tell you about getting this feasibility off the ground elsewhere?
Yeah, so just over 300 were assessed for eligibility, and of those, just over 200 were approached. So there were quite a few patients that weren't eligible. Some of those were just to do with, the types of surgery that they'd had. But the highest number really was to do that they were unable to access a smartphone or to take photos of their wounds. There were just 38 patients that had that. Once we got over that, the actual recruitment was 60%, which is really high for an RCT. So we were surprised that the level of engagement that patients had, that they really wanted to take part in the study. In fact, when we were doing the interviews with the patients, they were saying things like, these are the patients who were in the usual care group, and they were saying, oh, I was so disappointed to be put into this group. I really wanted to be in the other one. So there was a real enthusiasm to be involved in the study and to be, patients wanted to have this extra wound monitoring. So they were delighted to be, that I think that was a big driver for a lot of patients. But probably the nux of your question, Martin, is about, is this prohibitive, this digital technology, is it prohibitive to patients? And I would say no, because Melissa's patients, they use this as usual care for a lot of types of surgery, and their patient engagement is really high. I think they've been doing it with, Melissa, you can come and tell me if I'm wrong here, for some patients who've had C-section. And I think you were saying that the kind of traditional follow-up where you maybe phone the patient or send them a letter, I think that was around 50%. But with the digital monitoring, it's about 90%. So actually engagement is a lot higher with this. But in terms of patients not being able to participate, actually, it's not just the patient that's recruited, it's the patient and a carer if they want, because often a lot of patients tend to be elderly. They'll have a son, a daughter, a carer, a relative. There'll be somebody with them who can either help them to take a photograph. Let's say it's on their back. It's difficult to take a photograph. They'll help them to take a photograph, or they'll help them to send off the photograph. In the Wisdom study, it is just a feasibility study, so it was a small number of patients. But we were surprised that I think it was around 50% of patients said that they needed some help or some assistance to either take the photograph or submit it. And that was higher than we were expecting. I think the bottom line was that the engagement was still around 90%. We were still getting patients who were submitting.
That's right. So, that's what I was getting at, really. You got quite a lot of, 60%, yes, I'll do it. And then if they said they'd do it, they did it. So I was just wondering
Absolutely.
about the reasonable number of people who didn't have access to a smartphone. Would it be worth considering, I suppose, in the future, loaning them a smartphone, and then they can bring that back at a subsequent appointment, because they're going to come and see somebody at some stage, aren't they?
That was part of the study. We'd got funding available to loan out smartphones or
right.
to pay for contracts to make it as accessible for patients as possible. But the uptake was really, really low. Melissa, I don't think anybody took us up on the offer for that. Do you remember? No?
Yeah, no, they didn't. So there was the offer there. But I think to Judith's point, like in a real world setting, the engagement, and we're covering specialisms including vascular, breast, obstetrics, cardiac, we've mentioned thoracic, renal, etc. across the board. If you were able to sustain a rate of response over 85%, and that's without telephone or postal follow-up to sort of bring those numbers up. I think in the real world, the practice is largely acceptable to patients and their families or carers.
Yeah, thanks.
I think in the paper, was it half the patients required assistance from a carer or a relative to take the photos? Is that?
Yeah.
Yeah.
It was
Huge.
It was either to take the photo or to submit the photo.
Okay. You probably don't know, but well, it was all cardiothoracic surgery, so the photos should have been at the front, not at the back. Hopefully.
It does show you, though, how good photographs from a smartphone are these days. I think it was just under 100% were suitable for assessment. So that's pretty good to start with, isn't it? The quality of the photographs that are available. And, how well did it perform then, agreement between the clinicians who are having these things flagged to them and the AI flagging it to them? Was it good agreement?
Yeah, I think that one of the things to mention with this feasibility study was we weren't trying to reinvent the wheel. That is, we had already done the validation work in the first work package that Judith mentioned. We'd had clinical assessors as well as adjudicators working and comparing against the algorithm. And overall, so this wasn't powered to demonstrate any sort of sensitivity or specificity. But I think the overall agreement was around 87%, certainly higher than 85%. Yeah. Mm-hmm. And I think we looked at maybe 5 that the algorithm missed compared to maybe 39 that were flagged with no healing concerns. Okay. But that's the trade-off, isn't it?
So you're looking at on the side of caution, so that's okay. What about skin tones? Absolutely. How did it perform with regard to different skin tones? Because I've read some papers that suggest AI doesn't always perform quite so well with different skin tones.
Huge area in terms of equity and fairness in healthcare. And I think we're relatively novel in this space, where our initial work did include the Fitzpatrick score, which we used in Wisdom 1. And I think that looking across this, we found that the model didn't perform as well in dark skin tones in certain areas, for example, incisional separation. But interestingly, it tended to perform better with negative predictive values. So if you have an AI model that has the negative predictive value that classifies a wound as healing normally, you can be fairly sure that it doesn't have an infection. And that is important for what is effectively a screening tool, right? You want to make sure that if a patient isn't flagging, that in fact they are low risk. So you're not missing those patients that you need to capture. And in our first part of the work package, we found that the negative predictive value was higher for individuals with dark skin tones. So I think there is a lot more work to be done in this space. Judith mentioned Wisdom 1.1. And what we did in Wisdom 1.1 is we recognized that we needed to improve the model performance on the darker skin tones in some subgroups. And we did that work. And we're really excited that manuscript has been submitted. So watch this space.
Good on you. Well done.
Yeah, thank you.
I was going to ask, was that a matter of going back to the validation photos and getting more diverse array of images to feed it, or?
if we look at the sort of study timeline, the idea of doing a skin tone assessment was relatively novel. And when we begun this study, people weren't doing it as standard or routine practice. And I dare say they don't do it now as routine or standard practice. But what we've had in the interim is the increase of practice where we do have that ground truth or clinician assessment in a healthcare setting, where healthcare worker is obtaining the score at bedside. And that score that we've used there is the Hohen-Robinson, which is widely regarded in the UK as best practice. So for Wisdom 1.1, we did train the model on an entirely new set of images with that skin tone assessment.
And if I can chip in there, I think that is really innovative. I don't think, well, we're not aware of anybody else who's been doing that. So actually getting the patient in real life and assessing them and marking down what, using the Hohen-Robinson scale to say what is their skin tone. Melissa called it the ground truth. So what is their ground truth skin tone? And then looking at photographs from those patients. And that is novel. I don't think anybody else has been doing that.
Yeah.
I mean, if an organisation thought, okay, this looks great, let's try and implement this, what sort of infrastructure would they actually need to do this work, incorporate it in their routine surgical site infection surveillance?
Such a great question, because we often refer to the efficiency of digital. And then we, as Judith mentioned at the beginning of this podcast, you're increasing the workload. So how can we accommodate it? Now, if you have an existing system for telephone follow-up or postal follow-up, for sure, something using digital and AI as well will increase your efficiency by over 80%. You're going to do things a lot faster, a lot quicker. And in fact, you can do it more often. We call it proactive surveillance. So instead of waiting until the horse is bolted 30 days, yes, you did have an SSI. We're trying to pick things up as we go and actually intervene. So in terms of infrastructure, I mentioned Isla. In our case, that's the platform that we use. So we're looking for something that's browser-based. So you don't need to install an app or visit a portal. Pre-COVID, we did some preliminary work and found that patients weren't as keen to engage with portals or installing apps. They actually prefer a telephone, which isn't surprising, because you could ask questions. So what we did was we made sure we provided a solution where they could ask questions. But that's only one half of it. And indeed, AI is a part of that. The second part that Judith and I have been really interested in looking at is the workforce solution. So with Wisdom, what we found was the workers who were reviewing the images were maybe band 8 or, surgical registrars, consultants, and that isn't really effective use of resources because most wounds we know heal well. And so you don't need that sort of know-how with or without the AI. So what we've done at GSTT is we've reprofiled and rationalized that workforce. So we have a dedicated workforce across our multiple specialisms who are reviewing and responding to these patients. And then we have other work alongside of that, which I'm sure we can come on to in this conversation. But it's almost like, so now you're monitoring, what else would you do differently if you had that system in place?
Okay. What level are the people you've trained then to look at these images to make it more appropriate?
We have band 4s who can review and respond to the majority of our submissions. A steep learning curve for us when we initially set up this hub approach was we felt that we could use a lot more band 4s than band 6s.
Okay, so this is a registered healthcare practitioner, is it?
Band 6 would be a registered nurse. And what was interesting, because nobody had sort of looked at the healing pathway post-discharge, is we quickly learned that most patients were presenting with a concern that probably needed a registered nurse to review, whether that was of the antibiotics and liaising with the microbiologist or similar. So we have our band 4s, we have more band 6s than we had originally planned for. And then, of course, we have our higher bands who provide the sort of clinical know-how for SOPs, etc.
Just for our international audience, the difference between a band 4 and a band 6. Band 6 is a registered nurse, is that?
Yes.
Yep. And band 4?
Would be like a healthcare assistant or practitioner, a clinical research practitioner who can work under the supervision of a registered colleague.
Okay. I was interested in the fact you've trained it to look at different types of wounds, what the signs of infection, but also wounds separating and that sort of thing. Did it flag up things like dehiscence, and could it be used for that? And you said it'll find the stitch that should have gone, or a suture. So that's also useful information, isn't it? We're not just looking at infection here. It's other complications of surgery.
It's important to rule out surgical site infection, isn't it?
Sure.
And identify it for a dehiscence without infection, or a seroma without infection, or something like that.
Yeah. Yeah, I mean, absolutely, because there's a huge focus on surgical site infection being the outcome, but actually there's a lot of patients who have wound healing problems, but they're not infected. And that's a much bigger number. And those patients are still unable to get back to work or unable to get on with their normal life activities. So we're doing them a disservice by just focusing on the SSIs. We really need to be looking at the wound as a whole. So I think that's something that, we're able to do with the digital monitoring. And I think that's a really important focus for us to have.
So is that another area you're exploring then? Is it going to be able to categorize infection, seroma, hematoma, that sort of thing, or?
Yeah, so for us, we've looked at the early signs where there could be an intervention to improve that outcome for that patient. We are already reporting not just surgical site infection, but surgical wound dehiscence rates alongside of patients reporting new antibiotics for their wound after leaving hospital. So it becomes a really rich data set that you can, once you've done the confirmatory analysis, you can get quite confident in that follow-up care. I think for us, an exciting area is, what would you do if you noticed a wound breaking down? Because in the current digital pathways, your default is that you always have to refer to in-person review. And we are now looking at, well, what about helping with tech-enabled self-support? So you see on the platform that there's an issue with the wound, and for patients who are willing or able to self-manage, you can actually target resources, whether that's dressings, antimicrobial wipes, steri strips, MSSA decolonization, send it out to the patient, and then you follow them up. You have an enhanced recovery pathway for them where they're getting that support, you're answering the questions, and hopefully improving those outcomes. So to your question, Phil, about the dehiscence, well, yeah, it's opening up and we know it's more vulnerable then, right? But what are you going to do about that? So this is a whole new, when they say reimagine care for us in the UK, that's what reimagining care looks like.
I mean, because you're a tertiary referral centre, so presumably having to bring everybody back in could be quite a wide geographical area and considerable inconvenience to the patient to have to come all the way back in for a review when something like the system you've just described could actually prevent that and have a more local review, or you send them out something and you can monitor it remotely with photographs.
Yeah, it's not just the tertiary referral and the distance to the hospital. We've been doing a lot of work with the C-section women, and the study that Melissa was just talking about there, where you start off with the digital monitoring, but the digital monitoring is it gives you access, it's a gateway, and from that you can jump on and start doing other initiatives like, trying to get patients to self-treat at home. But for C-section women, for them, they've just had a baby via a cesarean section. They're exhausted, they're fatigued, they've got a baby to look after. The last thing they're wanting to do is to travel, even if it's a short distance, it's still huge inconvenience for them. So it's not just patients who live far, it's, most patients. And then another study we've been doing where we're, testing out getting patients to do their own wound swabs at home. When we've been interviewing those patients, again, they were cardiac patients, but they were just saying the inconvenience of having to get in a car, travel to the hospital. They're not allowed to drive because they've just had surgery.
Sure.
They said that for them, the convenience was absolutely a huge issue for them. So the more things that we can do in the patient's own home, the better. And the digital monitoring is absolutely facilitating that.
I was interested, you mentioned to get information on the post-discharge antibiotics that are given. Is that the patient reporting that themselves, or can you get that electronically from elsewhere, or you rely on the patient to say, "Oh yeah, I rang the GP and he gave me a course of X, Y, or Z"?
So we've done a confirmatory analysis looking at patients. I think we looked over a quarter, and we looked whether the patient said yes, they received these new antibiotics, or no, they hadn't. And we're really fortunate because we do have access to not only just like Care London, like not only our own organization, but within London, as well as Care summaries, which include antibiotics wherever they've been issued. So we can do this positive and negative confirmatory analysis, which we've already performed, and I think it was maybe around 97%, you know, that this was accurate data, whether they said yes or no. So for me, this is an area of extreme interest, because this should be feeding into antimicrobial strategies or stewardship. What I struggle with is we don't have a forum to report that to. We don't have the stakeholders that we're sending that to. And so one of my hopes is in the next year or two, we start to pin down, okay, surgical site infection rates are of interest here, surgical wound dehiscence here, and, you know, antibiotic use here, so that we can get that buy-in. Such a big piece of implementation is ensuring that you have that buy-in.
Curious to know about different specialties, surgical specialties. Colorectal surgeons deliver us the most complex and ugly-looking wounds frequently. Have you ventured down that specialty yet, or is it?
You had to be careful how you phrased that, then, didn't you?
We absolutely have. And pre-COVID, I was very fortunate to work with the most amazing patient and public engagement group from the Marsden, actually, looking at colorectal, which I thought would be almost a no-go. But what I heard was this was incredibly important. Maybe in some instances, they couldn't view the whole incision. There were concerns about the privacy of that information. So from our side, it's making sure there are features like the privacy blur, which goes over the image, so that unless you're actively reviewing it, you can't see it, or making sure that it's a secure platform. These things are really important. But for us working in these spaces, it's been eye-opening, and to say the least. We weren't sure that patients would pick up on digital monitoring because it was digital and they didn't know necessarily who was reviewing it. But the enthusiasm has been incredible, and that's what sustained us across the last number of years, really, is that this is something that the patients and public have actually asked for. Before even starting to look at the use of photographs, we commissioned a Patients Association survey asking for anonymous, views on the use of images for surgical sites recovery. And the overwhelming feedback of hundreds of patients and public was, yes, this would be a benefit, and actually this should be standard of care. We also reached out to GPs and asked them, would this help you either in your wound review or on your decision-making on antibiotics? And again, we heard back, absolutely, this would be a very valuable tool. So we don't have every answer for every surgical specialism, but where we have gone, it's been really well received.
Yeah. Great work. Well done.
Thanks very much. It's been fascinating chatting to you. To me, this is a story of optimism, really. It's not just about diagnosing wounds or replacing clinical judgment. It's about helping clinicians focus their attention to where it needs most and get the biggest bang for the buck with their time. And I think this approach is showing that it's practical and acceptable and safe, but it's also got to improve patient outcomes. So then you're going to have to move on to the bigger work to actually demonstrate that. But I think it's a really exciting glimpse of what the future of SSI surveillance could look like.
Following on to that, Martin, is, the hub that Melissa mentioned. Sky's the limit. I mean, we would really see this as a national hub. So for hospitals, if you're a small unit and you're not able to provide staff to, 7 days a week, to, availability to look at wounds, you could subscribe to this national hub. Your patients, they can just send their photograph straight directly to the hub, and there'll be a skilled, trained team there 7 days a week able to look at pictures. That makes it even easier for any hospital to get involved in doing digital surveillance.
Yeah, fascinating. Fascinating. Well, thank you very much. Great to talk to you again about wisdom second paper from this
Yeah.
piece of
Me
work.
too.
Look forward to probably in about 2 years getting on to the next piece of work. Phil, any final comment?
No, thanks, and I'm looking forward to your next papers. So just keep on bringing them. It's great.
We love surveillance. It's so important. Thanks very much, Melissa. Thank you very much, Judith. Thank you, Phil, as ever.
A pleasure. Thank you.
Thank you.
Look forward to talking to everybody in the next episode of Infection Control Matters. Bye for now.